Bismillahirrahmanirrahim. In the video 1, we have covered all the carcinomas of the lung. In this video, we will cover the rest of the tumor. As we have discussed earlier that about 85 to 90% of the tumor of the lung region are carcinomas, while mesenchymal carcinoid and other tumor comprises about 10 to 15% of the rest of the tumors. So recall this case scenario in which a 71-year-old man present to your office because of water retention. He states that he keeps himself well hydrated, but he does not feel that his intake matches his output. Past history revealed shortness of breath and weight loss of 15 pounds over past 3 months. He has smoked 2.5 packs of cigarette per day for 50 years, and chest X-ray revealed a coin lesion. Paraneoplastic syndromes are a group of rare disorders that are triggered by an abnormal immune response. About 1 to 10% of the people who have lung cancer, they exhibit the secretion of some of the hormones from the tumor cells. One is ADH, antidiuretic hormone, that leads to hyponatremia, and it is due to inappropriate ADH secretion. And then there is adrenocorticotropic hormone secretion that lead to development of Cushing syndrome. Parathyroid hormone or parathyroid hormone related peptide along with prostaglandin E are secreted by some tumors, and they are responsible for hypercalcemia, while calcitonin secretion is related with hypocalcemia. Gonadotropins are also released in some of the tumors, and they lead to gynecomastia. Serotonin and bradykinin are also released in carcinoid tumor. The ADH and adrenocorticotropic hormone, these are more commonly associated with small cell carcinoma, while parathyroid hormone related peptide or parathormone are more commonly secreted by squamous cell carcinoma. However, any tumor type can secrete any of these hormones. Other systemic manifestation of these lung tumors are: one is the Lambert-Eaton myasthenia syndrome. In this, the muscle is weak, and this is caused by autoantibodies directed to the neuronal calcium channels, and these antibodies are elicited by the tumor ionic channels. Then peripheral neuropathy, that is purely sensory, and it is due to anti-WHO antibodies, is also noted. And the dermatological abnormalities, acanthosis nigricans is associated with the lung cancer. Leukemia reaction, hypercoagulable state that lead to Trousers syndrome, that is deep vein thrombosis and thromboembolism, is also seen in these lung cancers. And hypertrophic pulmonary osteoarthropathy, that is associated with clubbing of the finger, is also part of this paraneoplastic syndrome. The lung tissue contains neuroendocrine cells, and they may be present as a single cell, or they may present as a cluster. When they are present in clusters, they are termed as neuroepithelial bodies, and some of these neuroendocrine cell, they tend to present as hyperplastic areas, and these are almost exclusively secondary to airway fibrosis or in an inflammatory background, while there is a distinct entity that is diffuse in idiopathic pulmonary neuroendocrine cell hyperplasia. This occurs in the absence of any inflammatory background. The benign tumorlets of these endocrine proliferations are small, inconsequential, hyperplastic nest of these cells, and these are present characteristically in the areas of scarring or chronic inflammation, while small cell carcinomas and large cell neuroendocrine carcinomas are also from these neuroendocrine cells, and these we have already discussed in lecture number 1. And the carcinoid tumors are separately discussed and classified separately because they differ significantly from carcinomas in its incidence, clinical behavior, its epidemiological pattern, histology, and the biological characteristic. They may occur in patients with MAN1, the multiple endocrine neoplasia syndrome 1 type. The carcinoid tumor are about 1 to 5% of all the lung tumor, and it occurs in people less than uh, 60 years of age. There is no preference for the gender, and 20 to 40% of the patients are non-smoker for these carcinoids, and they are low-grade malignant epithelial neoplasm in behavior, and their cell of origin is resident neuroendocrine cells of bronchial epithelium. They are of two types, typical and atypical carcinoid, while the no, small nodular accumulation of neuroendocrine cells that are less than 0.5 centimeter are called tumorlets, and they arise in the setting of interstitial fibrosis or small airway diseases, and these are of no clinical significance and incidental finding only. Morphologically, the carcinoid tumors are located centrally or can be present at the periphery. Grossly, they are finger-like spherical polypoid mass that protrude into the lumen of the bronchus, and the mucosa that is overlying this tumor is completely intact. It is about 3 to 4 centimeter in size and mostly confined to main stem bronchi. It penetrates the bronchial wall to fan out in the peribronchial tissue, just like the collar button, and hence it is termed as collar button lesion. The peripheral variety of these tumors are solid and nodular. So this gross picture is showing gross appearance of a cut section of a lung. This arrowhead is marking towards a carcinoid tumor that were proved histologically carcinoid, and the area distal to this obstruction is showing pneumonia. Here, this lung tissue is showing a carcinoid tumor that is marked by this yellow arrow. This is a discrete lesion, and it is polypoid in characteristic, and it caused hemoptysis and obstruction of the distal area that led to atelectasis. Histologically, the carcinoids are these tumors have got very thin, delicate fibrovascular stroma, and in this thin fibrovascular stroma, the cells are arranged in trabecular, organoid, palisading, ribbon-like, or rosette-like arrangements. Individual cells, it is quite regular and have uniform round nuclei and moderate amount of eosinophilic cytoplasm. Then there are two types of the carcinoid as we discussed earlier. One is typical type and another is atypical. They are distinguished on the basis of various cytology characteristics. The typical one have mitosis less than 2 per 10 high power field, while the atypical carcinoids have abundant mitosis. Necrosis is absent in typical, while it is present in atypical carcinoid. Pleomorphism is less in typical, while the atypical carcinoid exhibit more pleomorphism. Nucleoli are less prominent in typical one, while atypical one are characterized by presence of more prominent nucleoli. The growth pattern of this typical carcinoid is well fashioned while it is disorganized in atypical one. The lymphatic invasion is absent in typical carcinoid while it is present in atypical carcinoids. So this photomicrograph is showing a well circumscribed mass that is arising from the bronchial wall, and it is composed of uniform small blue cells that are arranged in sheets of cells and nests of the cells. Later these cells were proved positive for chromogranin and neuron-specific enolase. So it was proved that this is a carcinoid. Carcinoid, especially the typical carcinoid, are considered benign, by some authors. They are considered as benign counterpart of the small cell carcinoma of the lung. That is present on the another extreme, the malignant one, and in between these two, the small cell carcinoma of the lung and the carcinoid are the atypical variety of the carcinoid that lies in between these two in biological behavior. This is another morphological appearance of the carcinoid tumor that is showing that there are ribbons of these neoplastic cells that are separated by these thin vascular channels. Necrosis, when present in the carcinoid, is a feature of atypical carcinoid tumor, and this photomicrograph is showing us a central necrosis with the disorganized architecture of the tumor cells. Compare this picture from the picture we have earlier seen in the carcinoid tumor description. Here the cellular morphology is not uniform. There is a lot of pleomorphism and hyperchromasia, and also there is infiltration along the border. So these are the features of atypical carcinoid tumors. On electron microscopy, the carcinoid tumor exhibit dense core granules that are characteristic of other neuroendocrine tumors, and immunohistochemistry is positive for serotonin, neuron-specific enolase, bombesin, calcitonin, or other peptides. The carcinoid tumors are diagnosed incidentally on chest X-ray in a female of 55 years of age. The presenting feature or sign and symptoms may be due to the growth that is present within the lumen of the airway passage, or due to secretion of vasoactive amine from these tumors, or their capacity to metastasize. The growth effect, intraluminal growth effect, produce persistent cough, hemoptysis, impairment of drainage of the respiratory passage that leads to secondary infection development, bronchiectasis, emphysema, and atelectasis. Then secretion of vasoactive amine will lead to classic carcinoid syndrome that is characterized by intermittent attack of diarrhea, flushing, and cyanosis, and this is present in about 10% of the cases. The capacity to metastasize for these carcinoid tumors, they do not metastasize mostly, and treatment for these tumor is surgery, a surgical excision. The typical carcinoids have got a good, excellent prognosis, that is about 95% 5-year survival rate, while the atypical carcinoid have got 70% 5-year survival rate. The large cell neuroendocrine carcinoma has got 30% 5-year survival, while the worst prognosis is for small cell carcinoma, in which it is only 5% 5-year survival rate. This is the CT scan image of a carcinoid tumor, and that is showing that this carcinoid tumor that is marked by this arrowhead is producing an obstructive effect and subsequent atelectasis of the right middle lobe. The miscellaneous tumor of the lung include mesenchymal tumors that are inflammatory myofibroblastic tumor, fibroma, fibrosarcoma, lymphangioleiomyomatosis, leiomyoma, leiomyosarcoma, lipoma, hemangioma, and chondroma, while the hematolymphoid tumors include Lange cell histiocytosis, Hodgkin lymphoma, lymphomatoid granulomatosis, EBV positive B cell lymphomas, and low grade extranodal marginal zone B cell lymphomas. The pulmonary hematoma are relatively common, and they are incidentally diagnosed and basically present as a round radio opacity, that is coin lesion on chest X-ray. Sometimes there is classic popcorn calcification on chest X-ray is also noted. The tumors, these pulmonary hematomas, are less than 3 to 4 centimeter in diameter and solitary in nature, and they are well circumscribed, composed morphologically of lobulated and gray-white appearance, and the consistency is cartilaginous. Histologically, they are composed of nodules of connective tissue, and these nodules of connective tissues are intersected by epithelial clefts. Usually they are located at the periphery, but sometimes they are located, 10% of the cases of these pulmonary hematoma are located in the bronchi, and when present in the bronchi they usually present with the obstructive symptoms. The connective tissue in these pulmonary hematomas is mostly cartilaginous, fibrous tissue, and fat is also seen. The clefts that separate these fibrous nodule are lined by ciliated or non-ciliated type of the epithelium, and there is presence of some specific genetic changes in the pulmonary hematoma, such as short arm of chromosome number 6 and long arm of the chromosome number 12, that is seen in mesenchymal component of the pulmonary hematoma. This gross picture of the hematoma is showing that these lesions are less than 2 centimeter, firm to cartilaginous in consistency, and discrete lesions that often have calcifications. This is small size lesion that is sharply circumscribed and present in the periphery. On cut section, it shows a lobulated appearance, and radiologically, it presents as a coin lesion. This microscopic appearance of pulmonary hematoma is showing that there are areas of cartilaginous tissue, and this cartilaginous tissue is separated by the epithelium that is respiratory type. This hematoma is composed of almost all of it is composed of benign tissue, and this area on the left of the diagram is cartilaginous in appearance, while other areas of vascular uh, proliferation, and also there is adipose tissue and fibrous tissue presence. All these tissues are present in haphazard pattern. The cartilaginous nature of this tumor make it difficult to biopsy this lesion because it moves like a ping pong ball during the biopsy. So this is the radiological characteristic of pulmonary hematoma, the coin lesion, that is a separate discrete lesion that do not grow over time. So this is the computed tomography scan image of the same case, that is showing that this coin lesion is there, and the differential diagnosis of a small round mass in the lung is granuloma, peripheral carcinoma, solitary metastasis, and hamartoma. The lymphangioliomyomatosis is an entity that affects young women of childbearing age. The characteristic lesion of this entity is proliferation of perivascular epithelioid cell, and these cells express markers for both melanocyte and smooth muscle cells. Some people also say that the perivascular smooth muscles are proliferated in this entity, the lymphangioliomyomatosis. The lesion is proliferation of these cells, and it distorts the involved lung, and due to this proliferation there is development of cystic emphysema like dilatation of the terminal air space along with thickening of the interstitium and obstruction of the lymphatic vessels. Most commonly involved lymph nodes are lymph nodes of the lung, mediastinal and retroperitoneal lymph node along with major ducts of the lymphatic system. This entity is associated with mutation, loss of function mutation in the tumor suppressor gene, that is the TSC2 or tuberous sclerosis gene 2, and this TSC2 is basically a negative regulator of the mammalian target of rapamycin or mTOR, and this mTOR is an important regulator of the cell metabolism. When the negative inhibitor or regulator of this mTOR is lost, there is continuous proliferation by the cell. Then the pathogenesis is still clear while the estrogen is present in perivascular epithelioid cells in this condition. These lymphangioliomyomatosis are thought to be derived from perivascular epithelioid cells, similar to the other lesions that are associated with tuberous sclerosis, that are angiomyolipoma and clear cell tumors. Grossly, the lymphangioliomyomatosis is characterized by extensive cystic change, as it is evident in this cross section of or cut surface of the lung tissue, that is showing the presence of numerous cystic spaces that are dispersed throughout the lung substance, while microscopically it is composed of these cystic spaces are composed of smooth muscle bundles in which the myocytes are arranged haphazardly. The lymphangioliomyomatosis present as dyspnea, spontaneous pneumothorax, hemoptysis, cough, and chylous effusion. The chest X-ray may be normal or may show diffuse interstitial reticular or cystic pattern. There can be presence of pleural effusion, marked hyperinflation of the lung, and pneumothorax. The pulmonary functional tests show markedly increased total lung capacity with decreased diffusing capacity and obstructive or destructive features. The course of disease is slowly progressive, and it spans over decades. As the hormones are linked with this lymphangiomyomatosis, the estrogen ablation therapy is mainstay of this mainstay of the treatment of this lymphangiomyomatosis. The oophorectomy, anti-estrogen, that is tamoxifen, and progesterone therapy are used as hormonal ablation, and the mTOR inhibitor, that one is the sirolimus. It can be used as a treatment for, but the treatment uh, for this lymphangiomatosis is lifelong. Uh, the ultimate treatment for this entity is lung transplantation. The inflammatory myofibroblastic tumor affect children, and it is most common lung tumor of childhood. It equally affects both the male and female, and it may remain asymptomatic or present with fever, cough, chest pain, and hemoptysis. On chest X-ray, there is a round, well-defined peripheral mass, and the calcification is seen in 25% of the cases. Grossly, it is a firm tumor that has got diameter of 3 to 10 centimeter and grayish-white in appearance. And histologically, these tumors are characterized by proliferation of spindle-shaped cells. Spindle-shaped cells are fibroblast and myofibroblast. There is infiltration by lymphocytes, plasma cells, and there is presence of fibrosis in the surrounding tissue. So the histological characteristics are presence of inflammatory cells, presence of foamy macrophages, and fibroblast presence. The subtypes of this lesion are fibrous histiocytic and plasma cell granuloma. Previously, it was thought that this is an inflammatory lesion, but there is presence of anaplastic lymphoma kinase receptor tyrosine kinase gene rearrangement, and activating rearrangement in this ALK gene that is located on short arm of chromosome 2 are present in these tumors. 5% of these tumors tend to invade in the surroundings such as mediastinum, esophagus, pericardium, and pleura. And treatment of this tumor is anaplastic lymphoma kinase inhibitor. 5% of the lesions recur after surgery. This photomicrograph is showing the inflammatory uh, pseudotumor or inflammatory myofibroblastic tumor of this lung, and here there is intersecting spindle cells, and there are scattered lymphocytes and macrophages present in the tumor substance. The pulmonary epithelioid hemangioendothelioma is a rare tumor that is low to intermediate grade vascular sarcoma, and it usually affects young age group, and more than 80% of the patients are female. About half of the cases are asymptomatic, while grossly they present with multiple pulmonary nodules. These nodules are oval shaped, and they have a central sclerotic hypocellular zone and peripheral cellular zones. So the nodule that is present within the alveolar space with a central sclerotic or hypocellular zone and peripheral cellular zone is the morphology, and these tumors tend to spread within the alveolar spaces. Individual cell show abundant cytoplasm with frequent intracytoplasmic vascular lumens that contain red blood cells, and tumor matrix is abundant and eosinophilic, while markers for these pulmonary epithelioid hemangioendothelioma are factor 8 CD34 and CD31. Similar type of lesions are also present in liver, bone, and soft tissues, and mean survival is 5 years. So this is pulmonary epithelioid hemangioendothelioma, and here these nodules are present within the alveolar spaces. So the tumor has tendency to spread within alveolar spaces in epithelioid hemangioendothelioma. The pulmonary blastoma are malignant tumors that resemble embryonal lung. There is a glandular component of poorly differentiated columnar cells in the tubule that lack mucus secretion. The intervening tumor shows spindle cell that resemble embryonal mesoderm. There is histologic overlap between pulmonary blastoma and carcinosarcoma that including the heterogeneous elements. The clinical features are also overlap, and they are of carcinosarcoma. And age group, despite this is embryonal, the nature is embryonal, this tumor is common in adults. The median age for this tumor is 35 to 43 years. It is associated with the smoking and poor prognosis, while the mutation seen in this tumor is beta-catenin mutation. The mucoepidermoid carcinoma and adenoid cystic carcinoma arise from the tracheobronchial mucus gland, and they are present in trachea or proximal bronchus, and they present as an intraluminal mass. And when they are present within the lumen, they present with obstructive symptoms, and it is difficult to resect locally, uh, and they readily metastasize. The pulmonary artery sarcoma is can be fibrosarcoma, leiomyosarcoma, osteosarcoma, rhabdomyosarcoma, angiosarcoma, or unclassifiable sarcoma, and it is usually diagnosed by clinical presentation as pulmonary hypertension. It grows within the lumen and as intraluminally and within the proximal arteries, and may extend worm-like to peripheral pulmonary artery branches and causes peripheral infarct. This photomicrograph is showing a pulmonary artery sarcoma. This spindle cell tumor is growing within the lumen of the vessel, and uh, it is composed of spindle-shaped cells. Both the Hodgkin type of lymphoma and non-Hodgkin type of the lymphoma can be seen in the lung, but mostly these are secondary. Primary lymphomas of the lung are rare, and when present, they are extranodal marginal zone B cell lymphomas usually. These arise from the mucosa associated lymphoid tissue, and they are often designated as mild lymphomas. These are low grade and has got a favorable prognosis. Diffuse B-cell lymphoma may also arise as primary pulmonary lymphomas. Now, the lymphematide granulomatosis is a subtype of diffuse large B-cell lymphoma that is present with nodular pulmonary lymphoid infiltrate, and there is frequent central necrosis and vascular permeation. It affects middle age group and immunocompromised patients. It is present in lung, kidney, skin, and upper respiratory tract. The infiltrates in this lymphomatide granulomatosis are angiocentric and angioinvasive, and there are small to medium-sized lymphocytes. Mainly, these lymphocytes are T cell that are admixed with variable number of large B cells, and these B cells express Epstein-Barr virus, and this Epstein-Barr virus is considered as a driving force for the proliferation. Uh, they are graded on the basis of percentage of atypical B cells that are present in the tumor, and graded as high grade and low grade. More than 50% of these lesions, the lymphomatoid granulomatosis, they develop into large cell lymphoma. This photomicrograph is showing lymphomatoid granulomatosis. In this picture, there is extensively necrotic nodular mass that consists of cellular lymphoid infiltrate, and this infiltrate is penetrating a blood vessel. This is marked by this arrow, and at and there is presence of polymorphous lymphocytes, small, medium sized and large atypical lymphocytes are present in the lesion. Then some tumors or masses may be present within the mediastinum, and these may be primary or secondary in this area. This table is summarizing the tumors that are present in the anterior, posterior, and middle mediastinum. The important tumors in the anterior mediastinum are thymoma, teratoma, lymphoma, thyroid lesions, parathyroid tumor, and metastatic carcinoma, while the posterior mediastinum may contain neurogenic tumor, lymphoma, metastatic tumor, bronchogenic cyst, gastroenteric hernia. The middle mediastinum is the site for bronchogenic cyst, pericardial cyst, and lymphomas. Then there is another term, that is chemodectoma. This chemodectoma has no clinical significance, and these are a small nodule of less than 3 millimeter in size, and they are lying adjacent to a small vein and composed of cells that resemble meningothelial cells, and they form minute pulmonary meningothelial-like nodule, and they are likely reactive and non-neoplastic and present in older women. Now metastasis to the lung. Metastasis to the lung is very common, and any tumor can come to this area through blood or lymphatic, or can invade the lung through direct extension. The esophageal carcinomas and the mediastinal tumor, they frequently invade this area. These metastatic tumors are present in about one-third of the cases of fatal cancers at autopsies, and morphology is variable for these metastases of the lung, and morphologically they appear as multiple discrete nodules. They are radiologically recognizable as cannonball lesions, and these are scattered throughout the lung, and particularly in the periphery of the lung. At other times, they may present as solitary nodule. They may involve endobronchial region, the pleura, or they may present as pneumonic consolidation. They may grow as foci of lepitic growth, and this pattern is common in mucinous type of the cancer. Then most common primaries to this lung come from breast, stomach, pancreas, and colon. This is the gross appearance of the lung, that is showing that there are numerous metastases to the lung that are from renal cell carcinoma. Here is another lung that is showing that almost completely there is uh, presence of these gray-white lesion of variable sizes that are completely destroying the lung architecture, and these are secondary or metastatic tumor to the lung. Radiologically, they resemble as cannonballs, hence termed as cannonball metastasis. This is another lung that is showing that there are many small 10 white variable sized lesions that are invading almost whole of the lung substance. Here is another picture that is showing that there are multiple 10 white similar lesions present, and some of the lesions are showing hemorrhage and necrosis also. Here this X-ray chest is showing what we termed earlier as cannonball. There are multiple variable sized masses that are present in the lung field in this posterior anterior view of chest X-ray. So this is another pattern of metastasis to the lung. Here there are interstitial linear markings and nodule formation. These gray-white areas are linear streaks or linear markings that are present in case of lymphangitic metastatic carcinoma. These tumors widely spread through pulmonary lymphatic channel and form sheath of the tumor cells around the bronchovascular channels. Clinically, the patient has got shortness of breath and cough, and on X-ray, they have got diffuse reticulonodular pattern. This is the CT image. Here it is showing that this diffuse reticular and nodular pattern of involvement by metastatic carcinoma, while in the left side there is large malignant pleural effusion. Adenoid cystic carcinoma is a rare primary neoplasm of the trachea, and it is a low-grade malignancy of the central airway. The mass lesion fill the lumen and lead to obstruction, and this clinically present as dyspnea. There is recurrent pneumonia also, and local infiltration, and subsequently lymph node metastasis. This rhomboid is pointing towards this tumor that is present within the trachea and almost completely occupying the lumen. This is the coin lesion. It is a discrete rounded opacity that has got a sharp margin, and it is completely surrounded by lung parenchyma, as it is evident by this CT image. So these coin lesions can be present in granuloma, carcinoma, or hamartoma. So I hope by now you can answer uh, this clinical problem.